Afternoon to you all. Welcome to the first abstract-driven session of the Marie Curie Conference 2026, and our session is titled Closing the Gap. My name is Richard Harding, and I'm the Executive Dean of the Florence Nightingale Faculty of Nursing, Midwifery and Palliative Care at King's College London and the Herbert Dunhill Chair of Palliative Care and Rehabilitation at the Cicely Saunders Institute, and it's also my great pleasure to be a trustee of Marie Curie. Today, we're going to be hearing from 4 speakers exploring topics of approaches in dementia care, equitable bereavement care in diverse communities, and financial insecurity in advanced illness. All of our speakers today have submitted their corresponding abstracts to Marie Curie, and they can be found in the British Medical Journal. Links to these can be found by clicking on the resources area within today's session. In terms of how we're going to structure today, each presentation will be around 10 minutes long, and then after that, we have the opportunity for you, the audience, to pose questions to the speaker. So please, can I ask that you pose your questions in the Q&A section that you have at the bottom of your screen. You should see a Q&A button. If you can post your questions in there and not in the session chat, that would be great, and then we can pick up the questions as they come in at the end after each presentation. So it is my absolute delight to introduce our first presenter, Taryn Penwan, who's a medical doctor, lecturer and researcher at the University of Dundee. And we are going to hear an abstract today on advanced care planning. So Taryn Penwan, over to you.
Richard, can you hear me?
We can hear you perfectly and see you.
Okay, I'm going to share my slide just now. Okay, can you see my slide?
Not quite yet. Don't know, Luke, if you're able to assist.
Yeah, Taryn, do you want me to share your slides for you? It's the same as you did before, so I don't know why it wouldn't be showing, but I can take over if you want. Oh,
1 second.
I think it's loading.
Sometimes it takes a few minutes. Great, we can see your slides, not yet. Now they're in presenter mode. Over to you, Taryn. Thank you.
Okay. Right. Good afternoon, everyone. So I will be quick for this presentation. So today I'm going to present results of our rapid review that we conducted last year, and we focused on advanced care planning interventions with and for people with dementia. Just a quick recap here that advanced care planning or future care planning is a process where individuals can articulate, discuss, and document their future care preferences. And it is associated with increased quality of life, satisfaction over care, and reduced full-time treatment as well. So it is recommended. And particularly for those with dementia, they tend to face a rather unique challenges, mainly due to their, fluctuating mental capacity, their gradual decline over time, and also healthcare staff ongoing limited knowledge to discuss ACP accordingly with this group here. So we need more of a tailored interventions for this group here to suit their needs. And we conducted a rapid review last year, so mainly just to criticize existence regarding ACP interventions, communication strategies with and for people with dementia, and also evaluate if these interventions are effective or not in terms of increasing its uptake, health outcomes as well. And we chose the rapid review because last year I was contacted by the policy makers and people from back home in Thailand, and they want to revise the dementia guideline after 5 years. So after a long negotiation, they gave us 3 months. So a rapid review is the only choice at the time, and I was leading the sub team there just to make sure that the process is robust and timely to fit the stakeholders' need because they need to launch their guidelines soon. And that just came out last Friday, I believe. I haven't read it yet. And we also reported early findings back to stakeholders back in Thailand last July, and those findings are used as a part of the revised guideline as well. And again, due to the time pressure, I was using JBI's critical appraisal tools just to determine the quality of the included articles, and then two reviewers were randomly assigned just to verify my assessment at the time. No articles were excluded based on their quality, and then findings were criticized narratively together. In total, we looked through 4 databases, so PubMed, Science, now, and Cochrane Central, and we included 25 articles in total, which I'm going to show you in the next slide. Overall, all of the included articles came from the global north, so from the States, the UK, Belgium, Netherlands, Singapore, Switzerland, Spain, China. There was one article that was conducted in next countries, but again, all are from the global north. In terms of context, so 11 articles focus in the multi-dwelling people with dementia and their carers. 8 were around long-term care facilities, 4 focus on acute hospitals, and 2 were on multiple settings. And in terms of the side by articles can you particularly quantitative in nature, 60 of them, 5 were qualitative or method, and no study focused exclusively on those with dementia, which is what we expected with the nature where families and carers will be involved with ACP process over time. So it tends to design as a dyad for multiple stakeholders. And from this 25, we rise the intervention to 3 interventions here. So the first one is video action aids, where healthcare staff video of those with who have advanced dementia to show carers and those with dementia to see what it might look like towards the end of their conditions, and use that as a tool to end education. The kind is interactive website where these are from Belgium, and they were all co-created by people with dementia and families, and the website include all of the everything really. So legal work in that country, knowledge around ACP, and also tools to help them co-create the ACP as well. And the last one, the nominal we found is interventions that have multiple components. So they are always tailored to stakeholders. So there could be elements where they focus on education for people with dementia, and then that was added on with some kind of a booklet for healthcare staff or carers to just help them focus on the community process and so on. And apart from these interventions, we also get the advice around how we can communicate appropriately this group here. And 2 key themes came out is that first one, most of the carers and those with dementia indicated when we discuss ACP, we need to address the lack of knowledge as well, particularly for the families and the people with dementia themselves, because they don't understand or can articulate what they might look like towards the end of their condition or the symptoms that they may along the way. And these articles are shared using a more of a context appropriate framework to discuss with them. For example, from article from Singapore, where the country is more collective by nature. So they propose to use more of a to country family and those dementia compared to the West, where people are more determined and realistic. So it has to fit the context as well. And they also suggest they used to um, have both approach and reactive with this group here. So discussion would be initiated and led by doctors or nurses, and we can also use some Western approach when some crisis arise and use that as a trigger point to discuss ACP as well. So just adjust accordingly. And so so intentions work. Short answer is yes, they work, but with a caveat that um, so far we found that 8 articles they reported an increased uptake of ACP, and 9 reported increased documentation of advanced therapy and care, meaning that the focus of over time, which is again a focus of ACP. We started from a very terminal care decisions, and that evolves a lot over time. And the terms we found is also again was led a lot from advanced active living will, DCPR, and so on, reflecting the nature of ACP. But older articles focus on end of life, and the more recent ones will be more robust. In terms of the health related outcomes, evidence shows a mixed results. So we found positive outcome in terms of ACP engagement, conflict care, reducing conflicts in carers, increase their increase home days, reducing acute admission, and increasing ACP knowledge and attitudes. However, there are still some mixed results in certain outcomes. So, for example, this reference found no significance between people with dementia of life or their sense of shared decision making, as well as the health cost as well. That doesn't differ that much, nor the and some articles from the States also show the differences in terms of the rate of burdensome treatment, nor the preferences of comfort care from carers. And last one from 6 countries, they also shows no differences in the hospitalized rates in nursing home residents with dementia either. So overall, we found that the tailored ACP interventions seems to improve its uptake with and for people with dementia in their context. In terms of secondary health outcomes, evidence remains with various health outcomes reported, and that again links to the vacillation of the notion of ACP, where we shift a lot throughout the years. So we might need some kind of concept what do we want to measure and just focus on that one to ensure a more robust future study and more informed guideline in the future. And also these articles, they very briefly discuss around cultural norms, how that affect ACP, and also the resources available or the lack of it rather that may affect influence of interventions and adaptability and quality as well. And that was it from me. So, oh yes, and the preprint of this list, if any questions or you want to full read, just feel free to follow this link here. Thank you.
Just on mute, Richard.
Thank you very much, Penman, for your presentation and for sticking to time. Much appreciated. We now have an opportunity for a few moments of questions. So please do type your questions in the Q&R section, which is at the bottom, Q&A section, which is at the bottom of your screen. You'll see a Q&A box, and we do have questions coming in. The first question, Penryn, was, Taryn, when you looked at the evidence, what was the strongest evidence? You listed a number of interventions which you could put in the box of effective. Within that, what appears to have the strongest evidence for an intervention to support people with dementia to use an ACP? What was most convincing in the evidence?
Yeah, sure. So the most convincing evidence we found is the multiple components interventions where you need to have several modalities for the target groups. You may need to include education sessions, structured discussion, and some kind of tools to help decision making, such as facilitated group or using booklet, that kind of thing. So you need several things at once, not just one singular intervention.
Okay, thank you. The next question, I think, is a really important one, which is about culture. How does culture affect ACP planning? And I know there are a number of reviews which have concluded a lot of the theoretical underpinning for ACP is quite Western, and people like Cheng Pei Lin and Yuxin Zhao have been doing work in Asia, kind of looking to understand what it means in the context of things like filial piety. So what are your thoughts there?
Well, I can tell that as a Thai person that the foundation concept of ACP is very westernized and it doesn't work well in Asian context because we are more, family oriented. So decisions making tend to be interdependent as a whole family unit. Which again, just that's why it has to be very contextualized as well.
Okay, thank you. Another question is about the effect on families of ACP. Do you think it might be reassuring, or do you think it might create anxiety? That's the question.
It goes both ways. So anxious family members create more anxious healthcare staff and people with dementia. And if they are more reassured, more informed, they are they are more enabling us to discuss ACP accordingly. So yeah.
Good, thank you. So, I mean, do any of the studies have families as primary outcomes, do you know, or are they always secondary outcomes, family outcomes?
About half focus on family and yes, they focus on family's perception of care, carer burden, sense of competence, but again, the evidence shows positive results for this group here.
And is there anything qualitatively about what families say about ACP? That might be quite revealing.
From the 5 studies, I think the main themes we picked up is that family wish they could know more, in particularly for the advanced dementia, what it could look like. They are not prepared, how their parents will be in that state of, cannot interact with the world. So they wish they could be more informed along the way so that they can prepare things ahead. And also the second thing that came up is that that links to the web-based interventions where they think it is very good and proper and they can do that in their own time. But there's a caveat that they have been playing around on the website and then so what? They have done their ACP online and then, what now? What next? So they need some more of a structured guidance as well.
Great. Fantastic. Thank you. Thank you for your presentation and for your reflections. And thank you for sharing the Medrix paper. And we look forward to accessing that and reading it. So thank you for making it open access for people. Wonderful. Thank you. It's my pleasure now to introduce our next speaker, who is Rebecca De Brun, who's going to speak on primary and community care service use, its effect on hospitalisation among people, continuing the theme of dementia in the last 3 months of life. And Rebecca is joining us from her role as a researcher within the Cicely Saunders Institute at King's College London. Thanks, Rebecca, and welcome. And if I could remind you, audience, to keep putting your questions into the Q&A box as Rebecca presents, please.
Richard, I think Rebecca might have dropped out.
Okay.
Having a couple of tech issues. Shall we move on?
Yes, absolutely. Very happy to move on. I'm sure we can re-find Rebecca and she'll be able to present after the next speaker. So I'm delighted that we have two speakers joining us for the next presentation. We've got Sabrina Bajwa and Katrina Mayland, who are going to speak about equitable bereavement for all. Sabrina's a clinical reader at the Cicely Saunders Institute at King's College London, and Katrina is senior clinical lecturer at the University of Sheffield. And I'm delighted to have you speak together this afternoon. Thank you.
Can you see the slide?
We see and hear you just fine.
Great, thank you. Katrina's going to start, so I'll hand over to her.
Thank you, Sabrina. Yeah, I'll start and then we'll switch halfway through. So just to put a bit of context, we know that there's long-standing inequities that mean ethnically diverse communities experience worse health outcomes, and bereavement and the impact from that is no exception. Although bereavement is a universal experience, access to support remains unequal and inequitable. Services are often framed in a white model of care, and a previous research study showed that services reached fewer than 1 in 20 people from ethnically diverse communities. Next slide, please. So in this context, our study was focused on a conviction that equity doesn't start by identifying deficits, but rather it should recognise and value assets in ethnically diverse communities, recognise the knowledge, the compassion and resilience of these communities and build on that. So in that principle, our aim was really to look to understand the bereavement experiences and needs and to think together how we can start to identify solutions to address issues. Next slide, please. In terms of what we've done, we have delivered the largest qualitative UK study to date on bereavement experiences among ethnically diverse communities. And by recruiting, interviewing and conducting focus groups with 120 bereaved people, we have challenged the belief that ethnically diverse communities are hard to reach. The number, 120, was 50% above our target of 80. We also interviewed 23 staff members from 12 different bereavement services who were undergoing work to try to become more inclusive and diverse in the service they provided. This resulted in the production, a co-production of a short film, and subsequently conducting 4 co-design workshops, which will be the focus of the rest of the presentation. Next slide, please. Just to put, again, a little bit of context of what the key findings were from earlier phases, participants shared lifelong examples of racism that extended into end-of-life care and on occasion also impacted the bereavement support. This eroded trust and compounded the emotional trauma of our already distressing situations. Because of some of these experiences, services were perceived that they were culturally unsafe and unable to understand or accommodate the diverse needs in terms of culture, language, religion, or spiritual needs. This led to cultural exclusion. However, where there was true partnership with communities and support was able to be tailored to consider intersectional characteristics, this helped build trusting relationships, but required investment in time and energy. Next slide, please. Co-design within this study was essential because traditionally bereavement services are designed from a top-down approach that don't involve the communities that they should be serving right from the onset in terms of the planning. This can perpetrate ongoing inequities in terms of on a systematic level. Where co-design is truly collaborative, there is power sharing, and this ensures that the communities are partners and not just passive recipients. This is critical for meaningful, sustainable change. And I'll hand you over to Sabrina. You're muted, Sabrina.
You're on mute, Sabrina. It's just at the bottom left.
Yeah, sorry,
Yeah.
thank you.
No.
So I'm just going to run through the methods. We use an adapted experience-based co-design approach. This method is particularly appropriate as it focuses on narratives and visuals and shared reflections rather than written materials, which was really important for those who speak English as an additional language and may experience literacy challenges. So what we did is we triangulated our findings from the first two work packages, which identified the key touch points, i.e. focusing on moments and emotional responses in the bereavement experience. And we really broke down the bereavement care that people received in terms of those emotions. And then we used the anonymised scripts from those interviews and focus groups and filmed with actors a 10-minute catalyst film. And some of the pictures from that film are shown here. In line with the EBCD approach, we then had the 4 co-design workshops and a national hybrid event. So our experience-based co-design method really focused on inclusivity, and this was a real priority for us. First, in recruitment, we moved beyond the voices. So we worked with our community partners and our 8 community researchers that we'd recruited in the first 2 work packages to really reach the individuals who are often underrepresented in co-design like this and are often less likely to volunteer for this sort of co-design. We offered different ways to participate, so it was in person, online, and we were flexible, and we provided remuneration and practical support such as travel reimbursement to reduce participation barriers. Second, we actively addressed power imbalances. We offered separate preparation sessions so participants could build confidence before the mixed workshops. And we used neutral facilitation, agreed shared ground rules, and structured discussion in small groups before we moved into the big group conversations. Really importantly, we used a persona case study developed from the interviews in the first work package. This was somebody called Amina Begum, and it really represented the needs and bereavement experiences that had come through in the first work package. And this allowed discussion for the participants without self-disclosure, which is incredibly important for participation. And we also used methods which allowed all voices to be heard. For example, brainwriting, which is when you get everybody to write their ideas down before discussion, and dot voting, so that people were able to say without talking about which their preferences were in the co-design. Third, we made participation accessible and flexible, so materials were written in plain language, sessions were offered in the hybrid format, but also we had translators as well with the people who required them. We also recognised that sharing lived experience can be emotionally demanding, so we built in check-ins and support during the sessions. And finally, and most importantly, we shared decision-making power. Participants didn't just share their experiences, they helped identify the priorities and co-designed solutions and agreed on actions with us. So our co-design workshops and a national hybrid event brought together bereaved individuals from ethnically diverse communities, the community researchers, stakeholders, including service providers, commissioners and policymakers. So we had over 60 bereaved individuals from 10 different ethnically diverse groups. We had our community researchers as well and stakeholders contributing across the whole co-design process. So we began with the separate workshops for the bereaved participants and stakeholders separately. This allowed us to create safe spaces to explore those needs and experiences and systemic barriers. Within these workshops, we use the Catalyst film that we developed from work package 1 and 2 to stimulate discussion. So bereaved participants shared personal experience of accessing bereavement support, highlighted issues around cultural safety, accessibility and trust, and stakeholders reflected on organisational and structural barriers and opportunities for change. We then brought together both groups in a joint workshop to co-design solutions. These used the persona case study, and participants explored how services could better meet culturally diverse needs and focused on improving trust, communication, accessibility and cultural safety. So these discussions also identified practical strategies for implementation, including working with trusted community organisations as well. So finally, we had a national hybrid event which brought together all the contributors to review and refine the recommendations, ensuring that they reflected shared priorities and were actionable. And this doubled as our celebratory event, as it is part of EBCD, to really say thank you to everybody that took part in our research. So communities and stakeholders co-produced 4 clear priorities. So the embedding cultural safety and anti-racism training were very, very clearly set as a priority, and ensuring that there's accountability across all bereavement and palliative care services for this. Equitably resourcing grassroots community-led organisations as equal partners to larger mainstream bereavement services, diversifying and supporting the workforce, including leadership representation, and delivering accessible, culturally resonant support in trusted community spaces. Really importantly, establishing implementation and accountability through an equitable bereavement care charter with measurable outcomes was a key recommendation. Key take-home messages really are around the co-design and how to really make sure that this is done effectively with these groups. So co-design is often described as difficult or unrealistic in these groups, and our experience shows it is possible, and not only possible, but to do effectively. However, inclusion requires resource, and that includes monetary resource as well as time. Building trust with these communities takes time as well, and power sharing must be intentional and not just a tick box exercise. But when power sharing and inclusive co-design does happen, it produces better research and leading to better policy. So we wanted to just share our dissemination film with everybody, and there's a QR code for it. And the beginning part of the film is actually the Catalyst film, part of the film that we used for the co-design workshops, so where we'd use the quotes and the touch points, and then at the end we've added the recommendations. So please do have a look at that. And finally, we wanted to say thank you to everybody that took part in the research. We're extremely grateful, and it couldn't have been possible without you. Thank you.
So Richard, you're
Yeah,
on.
got it. Thank you so much for your presentation, and thank you also for sticking to time, both of you. We're getting some questions coming in, so I'm going to go straight into that. So it's an interesting question about sampling. So do you know that the volunteers for this project represent wider community beliefs and willing to participate, or could you argue that there are already people that are predisposed and willing to kind of work in a different way and be part of this? So how representative do you think these people are?
Do you want me to go?
Yeah.
Okay, I guess I'll answer that in two kind of ways. So in terms of sort of representativeness, we did compare our sample to like the national census sample, and we're able to see which groups were represented, overrepresented, or underrepresented. But in terms of actually the individuals participate, yes, and sort of when we've been reflecting and writing up our results, there may have been some selection bias that people more predisposed to speaking about bereavement, might have been encouraged to participate. But saying that, actually, the focus groups in particular were quite almost therapeutic in some ways. People saying it's the first time they'd ever spoken about this, and being able to share was really kind of beneficial, and they hadn't had the opportunity to do that before. So I think our sample generally did represent a lot of different views, but there is potentially some element of bias in there that we need to acknowledge and recognise.
Thank you, Katrina. Another question. People are clearly very impressed with your recruitment. How did you manage to double the number of people that you targeted to reach? Do you have any top tips for other researchers for recruitment?
Should I take that, Kat?
Yeah.
So just to highlight that we, in doing this research, not only did we recruit a large number of people, but actually as a result, we've actually recruited to the largest qualitative study of ethnically diverse participants in UK healthcare history. So I think we've hit a landmark. So within that, we have, through the study, we developed something called the Respect, Trust and Equity model of recruitment. So it's a new model of recruitment for ethnically diverse participants, which really focuses on that triad and actually talks about how we operationalized each of those really important aspects. And really importantly, at the core of that model of recruitment is cultural safety, so acknowledging racism and people's past experiences of racism. And it's an asset-based approach to recruitment, so not looking on these communities in a deficit way, that coming from a perspective that these are communities that have many, many assets and we want to work alongside them. So that our model of recruitment that we've developed through this study and then tested in this study is currently under peer review at the BMJ. So it has been for the last 2 months. So we are on tender hooks at this end. So please watch this space. If it doesn't get in there, it will hopefully get in somewhere else.
Somewhere else. Great. Well, there's another question asking how people can access your recruitment approach. So hopefully that will be the answer when that paper comes through. Last question that we've got time for. What were the challenges of using the EBCD and how was it adapted for the study?
I can start. I mean, I guess there's a particular kind of model framework that we looked at from the literature, and that was sort of what we used initially to draft. And traditionally, I think it's often been more, say, healthcare sort of issues that have been reported. So there's been involvement of healthcare staff in that. I think the key thing was about the creation of the Catalyst film. That's what we took, that actually that was a really useful way to kind of stimulate discussion, to really challenge and show emotion. And that was really helpful in bringing sort of these experiences to life. So they had much more meaning and resonated with the people who were then viewing the film and using that to build on the recommendations. I don't know whether, Sabrina, you've got anything else you want to add from the course in that or training?
Yeah, no, I agree with all of that. And I think for me, it was always thinking from the outset about how we can make EBCD as inclusive as possible. So it was about thinking about the people who have English as an additional language and say have challenges with literacy. So it was really about adapting that in those equity terms, which hopefully I talked about in that slide, but it was about having the interpreters available, the small breakout rooms, and really thinking about the power imbalances that can happen sometimes in those larger groups. So I think if you really think about from the outset, when you develop methods, that you think about those people who are most on the margins when you're developing your methods for co-design, I think then that works well.
Fantastic. There are more questions, but I'm afraid we've run out of time. But thank you for a very stimulating presentation. And yes, we look forward to the publication of your recruitment strategy, which I think we could all learn from. Now we're going to take a comfort break. So if I could ask you to rejoin us at just before 10:02, and we can start the next presentation at 13:50. Thank you so much, everybody. Good afternoon, everybody, and welcome back from the break. Thank you to our first three wonderful presenters in 2 sessions. And now it's my pleasure to move to our third presenter in this abstract-driven session. And Rebecca de Bruyn is here. Rebecca, it's great to have you with us. Rebecca is a researcher at the Cicely Saunders Institute at King's College London, and is going to speak to us today about primary and community care service use and its influence on hospitalisation and dementia. Rebecca, please share your slides, and over to you.
Thank you very much, Richard. Get these up. Oh.
Fantastic. We see your slides perfect, Rebecca. And if I can encourage people as you're listening, if you'd like to go into presenter mode, and if you'd like to post your questions in the Q&A section as before, that would be great. Thank you. Rebecca.
Sorry.
Slides then, but we've lost them again.
Yeah.
They're coming back. If you'd like to go into presenter mode.
There we go.
There we go.
Okay. All right. Thank you very much, Richard. And thank you everyone for being here today. As Richard said, I work at the Cicely Saunders Institute at King's College, and I'm new to the research world. My background is as a clinical nurse, and I then did my degree in epidemiology and have just joined this research team now. So this is my first research conference presentation in my research career. I'm excited to be presenting the preliminary results from a study looking at the influence between primary and community care services on hospitalization among people with dementia in the last 3 months of life. This is part of a wider mixed methods research study, and I'm presenting the preliminary quantitative results today. The PIs of the study are Dr. Therese Johnson and Professor Catherine Sleeman, and the study was funded by Marie Curie and the Alzheimer's Society. So a bit of background to start with the motivation of the project before we move into how the project was done. So we know that for people with dementia, unplanned hospitalizations are common, and they're even more common near the end of life. with estimates that 40% of all the unplanned hospitalizations people with dementia will have are going to happen in their last year of life. And we also know that hospitalization is associated with poor clinical outcomes for people with dementia compared to people who don't have dementia. They are more likely to experience things like falls, delirium, or get infections in hospital. And qualitative research has also showed us that these hospitalizations can be burdensome also for the family carers of people with dementia. And they've described using emergency or using hospitals as sort of a last resort when they're unable to access the care that they are seeking within the community. So in this study, we really wanted to dig into that and look at what are those community-based care services that could help people with dementia avoid these unwanted hospitalizations at the end of life. So to answer that question, we utilized existing data from the Marie Curie Better End of Life project. This part of this project, there was a survey administered in 2023 with help from the Office of National Statistics to a large representative sample of families across England and Wales who had registered a death of a family member, of an adult family member, and over 1,000 survey responses were received. This data is particularly interesting because it includes multiple choice questions that we can use as quantitative data, and it also includes free text answers. So the larger study is going to integrate this data together, the quantitative and the qualitative, in a mixed methods approach. But today, the preliminary results we're looking at are just from the quantitative. So, like I said, we had over 1,000 survey responses. The subset of those responses that were about people who had dementia was 360. And then we needed to exclude people who were in hospital during the entire recall period, as well as people who were missing data on the outcome, which is hospitalization. We weren't able to analyze those surveys. So we are down to 339 surveys forms the survey sample, the cohort for this study. Looking quickly at those 339 people, we know that their median age was 88. They were predominantly female, 61% female, 39% male. And most of the surveys were completed by children of the person who died. Looking at the bottom of the screen here, we also see that 63% of the people were actually living in a care home during these 3 months prior to death, and 37% were living in a private home, so either on their own or with other family members or friends. Amongst the study sample that we had, 50% of the people were hospitalized at least once during those last 3 months of life. We do have some data on the number of times that they were hospitalized, but we have looked at hospitalization just as a any or none. When we look at the people who were hospitalized, if you look at the right-hand column on the screen here, we can see that people who were hospitalized tended to be younger than those who were not hospitalized. They were more likely to be male, so 61%, 62%, compared to the 38% who were not hospitalized. And they were more likely to have comorbidities. So you see down 2, 3 or more comorbidities, they were more likely to be hospitalized than those without comorbidities. Also very interesting to point out at the bottom, we see that people who lived in a private home were more likely to be hospitalized than people who lived in a care home. So 66% of people who lived in a private home were hospitalized, but only 41% of people who lived in a care home were hospitalized. Moving now on to the use of different services within the community in the last 3 months of life. This graph represents the proportion of people who had at least one contact with each of the services down the left-hand side of the bar. So for example, GP face-to-face, people had about 3/4 of the people had contact with the GP face-to-face. Within the last 3 months of life, about half of them had contact with the district nurse, and about 30% had specialist palliative care. The other services that we measured were actually quite low in usage. For example, only 10% of the whole study sample of people who had dementia, diagnosed dementia, had contact with a dementia nurse during this time. Here we can see that care service utilization separated by living location. So amongst the people who lived in a private home on the left and the people who lived in a care home on the right, we can see that there's a different pattern for care service utilization based on where people are living. So for example, people in a care home were more likely to see a GP face-to-face, whereas people living at home were more likely to have contact with a district nurse. Specialist palliative care was accessed by about a third across both settings, and dementia nurses were also accessed by about 10% roughly in both settings as well. What is interesting also to note here, because we have such little usage of some of these services in the data, we actually weren't able to take those services forward into the inferential statistical analysis, and we did the regression modeling just on the top 4 services because those are the ones that we had enough data to model. So this figure represents, I don't know if this is blocking. Sorry. This figure represents the statistical analysis plan for the study. And so on the left-hand side, we see the 4 services that we put into regression modeling. And we used a modified Poisson to estimate prevalence ratios of basically saying, are any of these services associated with more hospitalization? And we were able to adjust that model for these individual characteristics. And then we included living location as an effect modifier of that relationship. So we can actually model, is there an association between GP face-to-face visits and hospitalization for people in a private home? And is there an association between GP face-to-face visits and hospitalization for people in a care home? So doing this modeling, we end up with 8 different key results, which are represented on the next slide. There we go. I'm not frozen. Okay, sorry. So just like to highlight again that these are preliminary results. So please don't disseminate further beyond this webinar. We are still working through the rest of the analysis. So this is a forest plot that shows the association between each of these care services and hospitalization. The purple lines represent the associations for people living in private homes, and the orangey brown lines for people living in care homes. When you're looking at this plot, this dotted line down the center at 1 represents no association. So everything to the left of the line shows that there was less hospitalization. There was a lower or a negative association with hospitalization and less likely. And everything to the right of the line shows that there was actually more hospitalization and there's a positive association with hospitalization. So what we found was that amongst people living in a private home, there was strong evidence that contact with a GP face-to-face was associated with less hospitalization. And likewise, for people living at home, contact with a district nurse was associated with less hospitalization. We can also see in this picture, because of how the purple lines and the brown lines show up, that the story is very different for people living in a private home versus a care home. So the key takeaways to this study are that in the cohort, 50% of the study was hospitalized at least once in the last 3 months of life, despite this usually being against patient and family preferences. We also know that those who were living in a care home had fewer hospitalizations overall. And we suspect that there could be an association, or there could be evidence that having in-person contact with a GP and a district nurse is in fact preventing unwanted hospitalizations. More research is needed on that, and we're hoping that integrating the qualitative findings will help us suss out that relationship more. Also, only 10% of people had contact with a dementia nurse in this study, and it was a nationally representative sample, to remember that. And again, a key point being that examining these care services based on living location, whether or not they were in a care home or living in a private home, the relationship between how those care services interact with hospitalization is different and warrants further investigation as well, which, as we integrate these findings with the qualitative findings, will be interesting to understand more. So thank you very much for listening, and I welcome the questions now.
Wonderful, Rebecca, and thank you for being to time. The questions are coming in, so thank you very much for that really interesting presentation. There are two questions particularly about demographics. So the first question is asking about gender difference for hospitalisation. It looked like men with dementia are more likely to be hospitalised. Are they more likely to live in a private home or a care home?
That's a good question. I worry that if I answer on the spot right now, I might not be 100%. I don't know if there's statistically difference. There was some differences in the demographic. I will say there's differences in the demographics between the people who were living at home and living in a care home. We noticed differences in terms of age, gender, socioeconomic status, and those differences are something that we looked at descriptively. But for the modeling, because we modeled separately the impact across living location and care home, we know that those demographic differences aren't influencing the results because we're adjusting for them out. But yes, they do look like separate groups of people. And that's one of the reasons we wanted to explore care home and private home separately, because we understood that these groups represent distinct profiles of people.
Okay, thank you. So I think that would be an interesting further discussion. So the next question about the demographics is about ethnicity. First of all, comment, great presentation. And then do you know the breakdown of ethnicity? Was this collected?
Yeah, we do. So there, across the whole cohort, there was only a little less than 4% of people who did not identify as white British. So it's one of the reasons that for the modeling side of things, we are not able to adjust for ethnicity because there was just not enough data in the ethnic minority groups. However, the cohort that we analyze does represent the ethnic breakdown of those age groups across those geographic areas.
Thank you. Thank you for that. Another question is about the broader literature. Do you know, in terms of hospitalisation in the last 3 months of life, do we know how dementia patients compare to other patients like cancer or organ failure, or how does dementia compare? Do we know?
Sorry, in terms of like rates of hospitalization?
Yeah, so you're looking at hospitalisation in the last 3 months of life, is that right?
Mm-hmm.
So how do you know, you may not know the answer, but do you know how dementia patients compare to other patients at the end of life, or cancer patients or heart failure patients, or do we know that?
I don't know the answer to that. I do know that with dementia patients, we are seeing that their rates of hospitalization tend to be lower early on and they increase towards the end of life. And I don't think that pattern is necessarily the same across different diagnoses.
Okay, no, we might be interested to look at that. Thank you. And then a link to an earlier presentation. Somebody's commented that we heard in an earlier presentation that care workers sometimes call on ambulance services regardless of care plans. Were you able to separate those living at home dependent on care workers or those living at home with family? Are you able to distinguish between that?
Yeah, so we do have that. Luckily, in this survey data, we do have that information. We have actually quite a bit of information looking at where and how they were accessing their primary care support in terms of day-to-day living. And it's something that we are going to explore more in terms of the descriptives as we continue this study. And we're also hoping with the qualitative stuff, it will help us understand that mechanism between what is happening between accessing these services and going into hospital, and what are these other factors at play. The quantitative data gives us, these really strong statistical statements of saying, yeah, contacting a GP, having access to a nurse is making a difference. We can get those nice discrete numbers, but tying that into the broader story of how this is influencing it is going to be important. I'll just say with the modeling, we did adjust specifically for people who were living alone versus people who were living with anyone, without qualifying what type of cohabitant that was, but just to highlight that was a distinct patient population we wanted to adjust for.
Great. Thank you very much, Rebecca, and thank you for your fascinating presentation. Thank you, and thank you everybody for the questions. And now it's my pleasure to introduce our fourth and final presentation for the day. We have three presenters. We have Caroline Mogan, we have Joe Williams, and we have Sam Quinn, and they're going to talk about advanced illness and financial insecurity. Caroline's a research fellow at Liverpool John Moores University. Joe is a mental health nurse and research fellow with the University of Southampton, and Sam is a research fellow at the University of St Andrews. So a nice multi-institutional presentation. Over to you, and everybody, if I could remind you as you're listening to pop your questions in the Q&A box at the bottom. Thank you.
Thanks very much for the introduction. My name's Sam Quinn. I'm at the End of Life Studies group at the University of Glasgow, and with my colleagues Caroline from Liverpool John Moores University and Joe from the University of Southampton, all three of us were research fellows on this study looking at advanced illness and financial insecurity. So I will just do the introduction and the methods for this presentation, and then hand over to Caroline and Joe afterwards. So to give you a little bit of context, many people will be familiar with the work that Marie Curie does around financial insecurity and advanced illness. We know that people with advanced illness can experience prolonged financial insecurity because of reduced income, because of rising care costs, and because of limited benefit entitlement in the UK. You may be familiar particularly with the work that the University of Loughborough have done with Marie Curie, a lot of that being the kind of large-scale data of how many people are experiencing financial insecurity at the end of life. In terms of what gap this study fills, little is known about how financial insecurity is experienced by people living with advanced illness and unpaid carers, particularly how things like housing and service-related insecurities intersect with geography and rurality. So I think that one of the USPs of this study is looking through that kind of geography, that rurality and geography lens. So we specifically, focused on urban and rural areas. I'll cover a bit more of that in the methods, but the overall aim of the study was to explore the lived experiences of people living with advanced illness and family carers experiencing financial insecurity in both urban and rural areas. So the way we approached this was a qualitative design, qualitative interviews across 3 sites, one in Scotland, one in North Wales and North England, and then South Central England. And each of the respective institutions had a lead researcher, a research fellow leading the data collection. So I covered Scotland, Caroline covered Liverpool, and Joe covered South Central England. We advertised for participants through things like social media, on the third sector, and we were seeking both, as I say, carers and people with advanced illness. Our transcripts were coded iteratively and analysed using a framework method. So we worked together. We had in-person analysis days where we came together, designed our framework, went back, applied it to our data, met again, saw what fit and what didn't. But there'll be more about the methods in the main paper that we are trying to publish. And the mean age of our participants was 52.2 for people who were living with conditions, and it was 58.1 for carers. And the map on the right just shows the numbers of how many were recruited across the different areas. So all of our, we class Scotland as rural and island. Most of our urban participants were from South Central England, and North Wales was our rural participants. So that's how we kind of divided it up. I will now hand on to Caroline to talk about the findings of the analysis.
Thanks, Sam. So 5 themes were developed from our data, and these included housing, social security, out-of-pocket costs, long-term financial insecurity, and perceptions of support. So I'll just talk you through each of these 5 themes. Sam, I think you're in charge of the slides, so next slide, please.
Yeah, is that changed?
Yep, great, thank you. So housing emerged as one of the key themes where financial and health insecurities intersected. So across each of the sites, so across urban, rural and coastal settings, participants described that their homes were just simply not designed for advanced illness. So physical limitations, such as narrow doorways, steep stairs, damp disrepair, made everyday care even more difficult. At the same time, people's emotional attachment to home, so its history, its identity and meaning, it meant that many people resisted moving, even when their homes no longer met their needs. So care was often delivered in environments that was fundamentally misaligned with the care that was needed during advanced illness. Participants who lived in local authority or privately rented accommodation also described the precarity of the kind of short-term tenancy agreements that they had, or no-fault evictions. And often this created fear of eviction during illness, which is when they most needed stability. We also found that utility costs intensified both financial and emotional strain. So participants spoke about the need to maintain warmth in the home, particularly when people became immobile. And this was at a time when energy costs were rising sharply. And as you can see from the quote at the bottom there, one participant told us that they had to scrimp and save to keep her grandfather warm. Next slide, please, Sam. So moving on to the next theme of social security. So this was described really, or these were described as essential, but also problematic. When they were secured, they enabled autonomy, dignity, and access to care. People also said that carer benefits, while modest, they were described as like a rare form of recognition. But navigating the system was frequently complex, confusing, and stigmatizing. A lot of people said that they weren't told what kind of care what type of support existed for them. This was particularly in those sort of rural or more remote areas where there was limited access to independent advice. People also spoke about eligibility gaps, and this was usually linked to home ownership or modest savings. And this produced a strong sense of injustice. And for some, these repeated refusals led to resignation and withdrawal from the system altogether. And there's a quote here at the bottom from a lady who'd said, that filling in the paperwork was really difficult as well. And that obviously added to extra strain. Moving on to out-of-pocket costs. So participants described a range of out-of-pocket costs that were associated with advanced illness and caregiving, and these extended beyond the sort of everyday household expenses that people had. Transport costs were a major issue, particularly in rural, coastal and island communities where public transport was infrequent and unreliable. We also found, interestingly, that in all contexts, car ownership was described as essential, mainly to enable people to get to appointments, healthcare appointments. But obviously the associated costs with running a car, such as fuel, tax, insurance, repairs, were obviously a drain on people's income and savings. Access to affordable food was also a concern for all of our participants. So people in the more sort of rural and remote areas described paying a rural premium for food because it was difficult for them to access larger, cheaper supermarkets. And this is where we saw community initiatives such as food banks become a real lifeline for people. Other expenses such as healthcare costs and funeral expenses added further strain. And the quote here at the bottom shows that many families ended up planning minimal funerals to avoid passing on debt. Next slide, please, Sam. We also found that advanced illness disrupts people's work and their income. So they told us that they had to reduce their working hours, take on lower paid jobs, or leave employment entirely, either as their health declined or as their caring demands increased. The financial impact was often immediate, but for many, this also marked the start of longer-term financial insecurity. After bereavement, we also found that some carers said that their social security entitlements that had usually covered basic living costs stopped almost overnight. And this was even while practical pressures were still so acute. So I think this shows that financial insecurity doesn't end with death. These pressures just accumulate and the consequences persist long after illness and caring have ended. Next slide, please, Sam. So moving on to our final theme. So our participants told us that community support, so informal support from charities or, neighbours was often present, but it was also conditional. Help usually came with unspoken expectations and repeated reliance on these informal mechanisms. People said that they could feel quite emotionally costly. In the close-knit communities in particular, the visibility of financial hardship intensified stigma, and people said this made it more difficult to seek help. So while proximity is often framed as protective in these small-knit communities, our findings suggest that it can also produce surveillance, judgment and exclusion. And next slide, I think moving on to Jo now.
Thank you, Caroline. Thank you, Sam, for moving the slides along there. So last couple of slides, colleagues, just to draw our presentation together. So conclusions that we feel we have drawn from our study are as follows, that financial insecurity compounds the challenges of advanced illness and it creates precarity, which is often shaped by geography, access to care and community context. And people adopt strategies such as budgeting and leveraging community supports, which Caroline has focused on when she has highlighted the themes, but also systemic gaps leave many vulnerable to ongoing hardship. Hardship is often normalised within communities, but we feel that it should not be accepted as inevitable. Secure housing and adequate welfare and affordable living costs represent the minimum requirements for comfort, independence to enable the reduction of stress at the end of life. Thank you, Sam. And so just to draw together our recommendations, so bear with me. So what we'd like to suggest is that it's important to recognise that precarity often persists beyond death and is transferred to bereaved unpaid carers. What we'd like to suggest is that we should provide a proactive post-bereavement offer, combining practical help. So, for example, social security changes, housing advice, debt and funeral costs. Emotional support coordinated through primary care preliminarily, and specialist palliative care and third sector partners, but also review whether bereavement payments and claim windows add avoidable insecurity. Guarantee an income floor for working age people with terminal illness. And we feel that this could be strongly aligned with Marie Curie's recommendations by guaranteeing a state pension level of income or an equivalent uplift. with access routes that minimise uncertainty and administrative burden for people living with life-limiting progressive conditions and their unpaid carers. Treat financial insecurity and housing instability as core to palliative and end-of-life care policy and practice. This requires routine assessment of financial insecurity, housing quality and adaptability, energy insecurity and key out-of-pocket expenses, which include things like transport and equipment. Keeping people with warm referral pathways, that's key to actually being able to resolve some of the insecurities that our participants reported. Warm referral pathways into welfare rights, housing support and practical help. We'd like to strengthen security for people living with advanced illness and reduce displacement risk. In England, build on the Renters' Rights Act reforms, and across the wider UK, pursue equivalent protections and enforcement approaches suited to each nation's housing system, ensuring that advanced illness does not increase exposure to eviction, disrepair, damp and unsafe living conditions. And our final recommendation is to invest in structural responses. This includes workforce capability and place-sensitive community infrastructure. By doing so, we would provide structural competency training so professionals can identify and respond to financial, housing and social security challenges. Fund community-led and third sector initiatives and on a sustained basis with delivery models fit for local geography and review feasibility of employment. So protecting paid leave for end-of-life caring informed by international examples such as Canada's compassionate care benefit. We'd just like to add, that's our final slide, and we'd just like to add that we wish to thank our participants for taking the time to share their stories and enabling us to have a deeper understanding of their lived experience. Thank you.
Thank you very much for your presence. Really, really fantastic. We have a couple of questions coming in already. First question is, what term did you use in participant-facing materials and social media instead of financial insecurity, which is quite an academic term?
Yeah, I can answer. Oh, can you hear me?
Yeah.
Yeah, sorry, I keep cutting out on this. So we decided, we worked with an excellent PPI member who very sadly passed away during the course of the project. But the term that we decided to use was struggling to make ends meet. So that was used on all sort of public documentation. We also use things like, finding it difficult to pay bills or, insecure housing and that kind of thing. Really interestingly, so I was working in Wales, and it was very, very difficult actually, and people seemed very sort of private about their finances. And I think more so than Joe or Sam said as well. So yeah.
Thank you for that. And another comment asking what the ethnic diversity of your sample was.
In Scotland, not particularly ethnic diverse, which I think is reflective of Scottish demographics as a whole, but I think Joe had more diversity.
Yeah, absolutely. I think across the whole study, it was predominantly people were identifying as white Welsh and white Scottish, very clearly in those localities. In southern central England, around the Southampton locality, it was slightly different. People identified across a wider spectrum in terms of ethnic diversity. And we did have participants we had two participants, one with who identified as Asian, another who identified as Black Caribbean. So slightly different, we would expect that more in an urban locality. So that is, one of the flaws, I guess, is that if we're going to think about, some of the issues with the study, that we don't have that broad ethnic diversity across the participants.
Thank you for having that data to hand. That's great. And then a bit of a comment on the effect of stopping working pensions. You gave an example of a daughter drawing her pension, and affected spouses. There's a comment that affected spouses also get long-term effects for the surviving spouse if you take your pension early. And just a kind of a comment on that, I don't know if there's anything you want to say to that.
I could go. Yeah, no, it's just true. It just seems to permeate. Like, it doesn't just stop when a person takes the pension, and if that person who takes the pension and then dies, yeah, it just rolls on to the family, and it's not the end of the financial insecurity. It certainly just like keeps going, if you like, even after somebody has died. You regularly find.
Thank you. A very important question, probably our last question. Thanks very much. That was fascinating. What are the next steps of the research? Will there be a publication?
Caroline?
Yes, there will be a publication. So we have just submitted to Palliative Medicine. And that's our joint findings from across the 3 sites. But we are also going to be creating individual papers from each of the sites, because actually we did have quite different findings across the sites. Yeah, watch this space. They'll definitely be out there.
Wonderful. Fantastic. Thank you all. Can I thank you to all of our speakers this afternoon? It's been a really fantastic abstract-led session. Can I just draw your attention to the chat? There is a Marie Curie report on dying in poverty, which I think is probably a recurrent theme for many research studies now. So the Marie Curie report is there in the chat. Thank you to all of our presenters. Great abstract-driven session, real diversity of methods and populations. So I would encourage you all to think about what you're working on right now, so that you'll be able to submit for next year's Marie Curie conference. It's a great opportunity to get actually what is now an international audience watching the Marie Curie conference. So huge thank you to the Marie Curie team who've organised this so well today. Thank you to our speakers, and also a huge thank you to our audience who have contributed questions today. Now, I can let you know also there's going to be a recording of this session, and I'm promised that will be up on the platform later today. So if you've got any colleagues who weren't able to attend today, you'd like to draw their attention to some data you've seen today, you will be able to do that. And if you've got any other comments, please do connect with our speakers. There's networking functions on this brilliant platform, or the Marie Curie team can be contacted also at research.info@mariecurie.org.uk, and I'm sure they'll pop that into the chat. But a real pleasure to chair you today, and thank you to the great presenters and to you, the audience. Enjoy the rest of your day, and we look forward to you attending the rest of this week's events. Thank you.